Hello, my name is Neeti. Today, I am presenting cardiovascular patient encounter seen in this clinical this week. Um, I will be using this both presentation for for a case presentation and SOAP documentation. The case involved a 68-year-old Asian male who presented to the clinic with a new patient evaluation for a chest discomfort. He established within the health system, but has not engaged in a primary care follow up for approximately 2 years. He presented today with a chief complaint of intermittent chest pain that occurs primarily with the physical activity. The patient reports over the past 2 weeks he's experienced a substernal chest pain. Pressure described as a heavy squeezing sensation. He rates the discomfort as a approximately 6 out of 10 intensity. The pain is consistently triggered or by exertion such as walking longer distance, climbing stairs, and performing a moderate physical activity. The discomfort typically lasts 5 to 10 minutes and resolves with the rest. He notes the symptoms has become progressively more frequent over the past week, are new occurrence within the minimal exertion compared to the baseline. He reports occasional radiation to the discomfort into the left shoulder and arm and the mild associated shortness of breath. He denies nausea, vomiting, diaphoresis, syncope, palpitations, and chest pain at rest. His past medical history is significant for the hypertension diagnosis approximately 12 years ago. He is currently suboptimally controlled with due to the inconsistent medication adherence. He also has a history of hyperlipidemia, prediabetes. He denies any prior history of myocardial infarction, heart failure, cardiovascular accidents. Current medication include lisinopril 10 mg daily, which is also report missing several doses per week, atorvastatin 20 mg nightly, as he also takes consistently. Family history is notable for his father, who died of the myocardial infarction in his early 60s. His mother history of type 2 diabetes mellitus and hypertension. He denies any known congenital cardiac condition in his family. Socially, he's a former smoker with the 15-20 packs a year history of quit smoke approximately 5 years ago. He reports occasional alcohol consumption. He leads to a largely sedentary lifestyle due to retirement, spends most of his day seated. His diet is highly in sodium and processed food with the limited intake of fruit and vegetables. A focus review of system reveals cardiovascular symptom of exertion, chest pressure, and mild exertion dyspnea. He denies palpitations, syncope, arrhythmia. Respiratory reviews otherwise unremarkable aside from the exertional shortness of breath. He denies gastrointestinal symptoms such as reflux, abdominal pain, bloating. Neurological review is negative for dizziness, weakness, and focal neurological deficit. On a physical examination, vital sign reveals blood pressure 156 over 90 mmHg, heart rate of 84 beats per minute, respiratory 18 breaths per minute, oxygen saturations of 97% on a room mirror, body mass index is 29 kgm2. He appears alert. It is no acute distress at rest. Cardiovascular exam reveals a regular rate and rhythm with no audible murmur, rubs, or gallops. Lung examination is clear to auscultation bilaterally without wheezing, rails, bronchi, and peripheral pulses are intact and symmetrical, and there are no peripheral edema noted. Overall, the presentation is almost consistent with exertional chest pain concerning for a stable angina with a possible progression towards the unstable angina given the increase in frequency and reduced exertion threshold given his multiple cardiovascular risk factor including hypertension, hyperlipidemia, former tobacco use, and former history of premature coronary artery disease. The likelihood of underlying coronary artery disease is high. Primary differential diagnosis includes stable angina or acute Syndrome with the ischemic heart disease spectrum. Additional consideration includes gastroesophageal reflux disease, musculoskeletal chest pain, such as a costochondritis, and less likely pulmonary embolism, given the absence of pleuritic symptoms of acute risk factor. Anxiety related chest discomfort is considered lower of the differential due to the consistent exertional pattern and radiation um, characteristics. The plan includes immediate and clinical evaluation of 12 lead ECG to assess his ischemic changes in his health. Laboratory studies will include cardiac biomarker and biomarkers if clinically indicated, along with the complete blood count, CMP, fasting lipid panel, and hemoglobin A1C. For the cardiovascular risk assessment, the chest radiograph may be obtained if the needed to rule out the alternative etiology. The patient will be risk stratified using ASCVD risk calculator, and urgent cardiovascular referral will be placed for further evaluation. A stress test will be ordered with the modality selected based on a baseline ECG finding and the clinical judgment. Medication management will be include initiation of a low dose of aspirin 81 mg daily for no with the if no contraindication exists. His statin therapy will be intensified to a high intensity regimen such as atorvastatin 40 to 80 mg daily. Blood pressure regimen management will be optimized through titration of his current ACE inhibitor and consideration of additional antihypertensive therapy depending on a follow-up evaluation. Sublingual nitroglycerin will be prescribed for the acute chest pain episodes. With the detailed education on a proper use and emergency precaution. Lifestyle modification will be strongly emphasized, including adherence to DASH diet or Mediterranean diet, gradual increase in a physical activity once medically clear, weight optimization, and continued avoidance of tobacco use. The patient will also, through education and warning signs of the myocardial infarction, including chest pain at the rest, worsening intensity, duration, typhoresis, nausea, addition to the jaw and the arm, with the clear instruction to seek emergency care immediately the symptom occurs. Follow-up will be arranged with 1 week sooner, depending on the diagnostic results, with the expedited cardiology evaluation recommended. Thank you.